Welcome back to The Explainer. Today we're diving deep into the microscopic world to uncover the pathogenesis of hepatitis E. We're going to break down exactly why this stealthy virus behaves the way it does inside the human body. And trust me, it's a fascinating ride.
Picture this. What happens when your body's own defense mechanisms destroy the exact organ they're supposed to be protecting? It's a biological irony that completely defines a hepatitis E infection. You might naturally assume the virus itself is tearing the liver apart. But the truth? The real destruction is entirely a case of friendly fire.
Here's our roadmap for this explainer. We're going to meet the virus, watch it hijack the liver, see the immune system strike back, check out the collateral damage, look at some fatal exceptions, and finally wrap up with diagnosis and treatment. Let's get into it. Section 1. Meet the hepatitis E virus. So, hepatitis E, it's a single-stranded positive-sense RNA virus, and it spreads through the fecal-oral route, which, is exactly as gross as it sounds. The classic clinical scenario, a patient traveling to endemic areas in Asia or Africa, drinking contaminated water or maybe eating undercooked meat like wild boar or deer.
Once it's ingested, the virus just cruises down the GI tract into the duodenum. From there, it gets absorbed into the mesenteric circulation and hops right onto the portal vein. Think of the portal vein as this massive biological superhighway gathering blood from the gut. It takes the virus straight to the liver's front door.
Section 2. Hijacking the liver factory. Once it arrives, the invasion is on. The virus basically turns our main liver cells, the hepatocytes, into its own personal manufacturing plants. It binds, slips inside via endocytosis, and drops its RNA. Then our very own ribosomes get tricked into reading this RNA to build viral capsids and an RNA polymerase enzyme. That enzyme just churns out tons of new viral RNA, which gets boxed up and shipped out via exocytosis.
But wait, here is that core biological irony we mentioned earlier. The virus itself, it doesn't actually blow up or kill the liver cells. Not at all. It just quietly uses them to replicate, shedding into the biliary system to be passed in the stool and slipping into the bloodstream. It is literally the perfect stealth operative.
Section 3. The immune system strikes back. Because if the virus isn't directly destroying the liver, well, what is?
The answer lies in our own immune system, and it attacks in two distinct ways. First up, the innate response. Hepatic macrophages called Kupffer cells sound the early alarm, dumping out cytokines. This makes blood vessels leaky, swells up the liver, and triggers a prodrome phase. Those vague, miserable flu-like symptoms. Then, a few weeks later, the adaptive response rolls in. This is the highly trained surgical strike team that kicks off the severe icteric phase.
Let's zoom in on that adaptive strike team. Picture an infected hepatocyte desperately waving a tiny flag, a piece of the virus displayed on its MHC1 complex. A CD8 T cell spots it, locks on, and basically says, "Target acquired." It releases perforins that physically punch holes right in the liver cell membrane. Then granzymes slip inside like snipers going straight for the nucleus. This triggers apoptosis, programmed cell death. Yep, our own CD8 T cells are blowing up our liver just to stop the viral spread.
Section 4. Collateral damage and symptoms. Let's transition from this microscopic warfare to what the patient actually feels in the clinic.
All of that early swelling from the Kupffer cells, it aggressively stretches the liver's outer casing, Glissen's capsule, which causes intense right upper quadrant pain. Meanwhile, all this swollen tissue physically pinches off the bile ducts. Since bilirubin can't drain into the gut like it's supposed to, patients end up passing pale, clay-colored stools. Instead, that bilirubin backs up into the blood, depositing in the skin, causing severe jaundice and itching, and filtering into the kidneys to make dark, tea-colored urine. It's a direct mechanical pileup from the inflammation.
If we draw blood during this phase, we see the sheer scale of the destruction. Liver enzymes, specifically AST and ALT, absolutely skyrocket into the thousands. This massive spike, that is the literal laboratory footprint of those CD8 T cells bursting open hepatocytes and dumping their internal content straight into the circulation. Section 5. The fatal exceptions. Now, for most healthy adults, hepatitis E is completely self-limiting. It clears up. But there are two highly vulnerable populations where this virus becomes incredibly deadly. The first exception is pregnant patients, specifically those in their third trimester. For this demographic, the mortality rate skyrockets to a shockingly high 15 to 25%.
If you have a pregnant traveler returning from an endemic area with these symptoms, that is the absolute highest risk scenario medical professionals watch out for.
In these pregnant patients, the liver can progress to acute, fulminant failure. It stops producing vitamin K-dependent clotting factors, creating severe, life-threatening bleeding risks. But it gets worse. It also stops converting toxic ammonia into urea, so that ammonia just builds up in the blood, slips into the brain, and pulls water along with it. This causes cerebral edema, massive confusion, and a deadly condition called hepatic encephalopathy.
The second fatal exception is immunocompromised patients. Think about it. If a patient is missing those crucial CD8 T cells, maybe because of HIV or transplant rejection medications, the virus just replicates entirely unchecked. It constantly damages the liver, driving rapid, aggressive fibrosis. While hepatitis C might take decades to cause cirrhosis, unchecked hepatitis E can destroy the liver in just 1 to 2 years. It's terrifyingly fast.
Section 6. Diagnosing and treating HEV. So, how do we solve this puzzle in the clinic?
Serology testing is our best tool here. It tells us exactly what stage of the battle we're in by looking for viral RNA and antibodies. If IgM and viral RNA are both positive, you've got an acute active infection. If IgG is positive, but RNA is negative, the patient had it in the past, cleared it, and now has lifelong immunity. But if the RNA is positive and antibodies are completely negative, we are likely looking at an immunocompromised patient dealing with a chronic infection.
For the vast majority of folks, treatment is just supportive care. You just give the immune system time to do its job. But for chronic cases in those immunocompromised patients, we utilize a drug called ribavirin. Ribavirin acts like a molecular wrench. It directly jams up that viral RNA polymerase we talked about earlier, manually shutting down the virus's entire replication machinery.
But I want to leave you with this lingering mystery. We can map the viral RNA, we can track the killer T cells, and we can watch the enzyme spike. Yet, modern science still doesn't fully understand exactly why a third trimester pregnancy alters the body to make hepatitis E so uniquely devastating. It's an incredible reminder of just how much we still have left to uncover about the human body. Thanks for joining me for this explainer, and stay curious.